morning. Thank you very much for inviting me to talk today to you about starting, maintaining, and stopping systemic steroid therapy. Thanks to Dr. Jassim for doing such a great presentation before me. And what I will try to do is I'll try to catch up on time since we're a bit behind. So hopefully it will be a bit short and give you kind of the basics of how we think about steroid therapy in general in patients who are on high-dose steroid therapy. So what we will do today is we will discuss the harmful effects of steroid therapy. So we'll go over some of the complications of long-term steroid usage and also short-term steroid usage. We will briefly consider how to monitor and control those complications, and monitoring and controlling the complications will just fall right off the complications themselves. So when we talk about type 2 diabetes, of course, you're going to monitor blood sugar, you're going to control blood sugar, and so on. And then finally, we'll discuss stopping or tapering steroid therapy, which I think is where I can give the most insight to people who are not endocrinologists, trying to kind of instill the insights that we get from dealing with a lot of patients with conditions related to adrenal glands, with HPA suppression, and that sort of thing. So without further ado, before starting systemic steroids. So what do we want to do before we start systemic steroids? The first and most important thing is making sure that the indication is evidence-based. A lot of our patients who are started on steroid therapy, who develop complications of steroid therapy, when you go back to the diagnosis, when you go back for the reason why they were started on steroid therapy, in many cases, the reason isn't very clear. We used to say, maybe it was an old saying, hopefully it doesn't, it's not taught anymore, which is that if the diagnosis is unknown, the treatment is cortisone. Let's stop doing that. So we only treat with cortisone and steroids at the correct dose for the correct indication, making sure that we have the right indication, and then giving the therapy when it's evidence-based. We always want to consider alternative therapies, and in the age of immunotherapies, we have a lot of alternatives that are great. So as much as possible, look at alternative therapies and try to avoid systemic steroids as possible. You can consider local steroid therapy for local areas of inflammation, or if there's a skin issue that is local, that can be treated locally, we do that. And we give the lowest dose possible for the shortest period of time possible, because the harmful effects of steroids are multiplied with the dose and the time. So you can think of it as the cumulative dose. So if the patient gets 5 milligrams over a whole year, that's a lot of steroids. If they get 10 milligrams for 1 week, that's a lot less steroids. Even though the dose is higher, because the period of time is shorter, it is less exposure, and so on. All right, so what kinds of harmful effects do we get from steroid therapy? So of course, the canonical example of you can think of as getting too much glucocorticoid exposure is what we get with Cushing's disease. So in Cushing's disease, or in fact, we should say Cushing's syndrome in this case. Cushing's disease is when it's from the pituitary, but when it's exogenous steroid, we call it Cushing's syndrome. So we get a long list of possible features that we can get in our patients. So it includes, hypertension, diabetes. They can develop acanthosis, hirsutism in women, and menstrual irregularities. There are issues with depression and mood changes, acne, moon-like faces, and this central obesity that is typical of Cushing's disease. And as endocrinologists, you will of course appreciate the skin finding of Cushing's disease, which is those broad purple stria that we see in patients with Cushing's disease, as well as the dorsal fat pad. So we used to call this the buffalo hump, but we don't like this description anymore. It's not nice to call our patients with those names, so we say dorsal fat pad now. What other problems can we get from Cushing's disease? So I'm going to go through a long list of systems, and each system will have a bunch of issues that you can get from Cushing's disease, from extended glucocorticoid exposure. Of course, this list you can always find by researching and looking at them on UpToDate and that sort of thing, but it's nice to always go over them as well, just as a reminder. So we got cataracts, increased intraocular pressure, and glaucoma. You get exophthalmos, are all reported with glucocorticoid therapy, but cataracts especially is very common, and glaucoma. So those two, if patients already have some cataracts, you want to document that, because you don't want the patient coming to you 2 years later saying, you gave me cataract by giving me steroids. You want to know where you're starting. You want to make sure you counsel your patient about those complications. Similarly, if they have any signs or symptoms that may suggest glaucoma, or if they are known to have glaucoma, be careful. You need to know that steroids can precipitate glaucoma and worsen it. So you want to make sure they're well managed, treated, and consult with their ophthalmologist before you start them on glucocorticoid therapy. Cardiovascular complications. So hypertension and heart failure, they get salt and water retention. Depending on the type of steroids, it might be more or less, depending on the type of steroids, but in general, all of them will get salt and water retention, basically, and they will get, in addition to that, they get worsening of heart failure due to the myopathy, because the cortisol itself will also weaken their muscles. So it has an effect on the muscle itself, as well as salt and water retention. So weaker heart muscle plus extra volume, a recipe for going into heart failure. So if patients have risk factors for heart failure or already have heart failure, you want to be very careful before starting steroids, systemic steroids. So again, today we're talking about systemic steroids, not, steroid cream, hopefully not an issue unless, very large area, that sort of thing. But systemic steroids, so oral or IV steroids, that's where we are worried. Atherosclerosis or accelerated atherosclerosis or premature atherosclerosis happens in patients who are on chronic steroid therapy. And then there are associations with arrhythmias, venous thromboembolism, and dyslipidemia. Those are weaker associations, but they are there and reported in the literature as well. Then we come to GI. So the most common, or the thing we worry about the most, is peptic ulcer disease. This is especially in patients who are also on NSAIDs, because a lot of your patients, they might have a skin manifestation of a rheumatological condition, and they might be on NSAIDs for their joint pains, such as if they have, any kind of condition that's affecting their joints. And in those cases, if they are on NSAIDs and you add steroids on top, it's a recipe for developing peptic ulcer disease. So you want to be careful about that. But even those who are not on NSAIDs can still develop peptic ulcer disease when you give them steroids. So you have to be careful about that as well. So if they have any risk factors or symptoms before of peptic ulcer disease, you want to treat and manage and control that before they go ahead. Osteoporosis is very important. So women, especially after menopause, they have higher risk of osteoporosis. Women who are near menopausal age, you're starting the process earlier of breaking down their bones by giving them steroids. But in general, not just women, any person at any age, when you give them high-dose steroids that you're planning to use for a long period of time, you really have to start thinking about their bones, because they will lose their bones. So this is what happens with osteoporosis is, oops, okay, let's start this again. Is the pointer? Okay, the pointer is a bit moves on its own. So this is normal bone matrix. So what happens with osteoporosis is that the bone matrix is reduced. So if you look at, this is bone with osteoporosis here. It starts as normal bone, and then over time, the trabeculae inside are reduced in their amount. And so bone becomes thinner or weaker, and then they have higher risk of fracture. So they will not have any symptoms with osteoporosis. This is a common question people ask. I have a patient who has osteoporosis and they have a lot of bone pains. Bone pains are not caused by osteoporosis. It does not cause bone pains. It's a painless disease. But what they can develop is they can develop fractures. If they have a fracture, they will have pain. But what I worry about a lot more actually is avascular necrosis of the femoral head. Now that can present with pain. So if you have a patient, you start them on steroids and they suddenly come to you with pain in their hip, you have to be very worried about developing this rare complications, rare but very important complication. In this complication, what happens is there is necrosis of the head of the femur, and if they develop that, a lot of them will unfortunately end up with chronic pain, chronic issues in their hip, and chronic difficulties with walking, and many of them end up requiring hip replacement just because we gave them high-dose steroids. So I just want to remind you of the risks that we're putting our patients at when we're starting high-dose steroids. Then you've got the neuropsychiatric issues. So you've got mood changes, memory impairment, and acute psychosis is especially concerning. So if someone develops acute psychosis, this is when you really have to stop therapy right away. But all the other possibilities are there as well. So you want to ask your patient about their mood, if they've had a change in mood, if they've developed a depression or anything like that, then you want to know about that. And also you want to counsel them about it before you start therapy. Otherwise, they might be upset that they developed something they were not expecting. So it's always better to counsel your patients beforehand. And of course, the immune system, and that's, in a lot of cases, that's exactly why we're giving the steroids. We're intentionally trying to suppress their immune system because they have an immune problem that's causing their skin manifestation or condition. So we're trying to suppress the immune system, but by doing that, with something like a steroid, which does a wide range of immunosuppression on all of the different components of the immune system, the humoral and the T-cell mediated, everything gets suppressed, so they are at higher risk of developing those reactivations of, for example, herpes zoster in the form of shingles, or reactivation of latent tuberculosis. So if someone had history of TB, you want to make sure they got treated for it. If they are at high risk of TB, sometimes you might want to consider, testing them before you start steroid therapy and treating their latent TB concomitantly with the steroid therapy if you have to. So this is if you're going to give high dose steroid for a very long time. This is when you start seeing the immunosuppressive effects. But the other effects, for example, when we talk about cataracts, when we talk about osteoporosis, this happens even with doses, for example, like prednisone 7.5 milligrams per day. If you give it for a long enough time, you will develop osteoporosis and you will get cataracts. So it's important keeping in mind the length of the duration of therapy there. But for immune suppression and opportunistic infections, that sort of thing, usually this happens more when you have patients on much higher doses of cortisone or prednisone or steroids for extended periods of time. And then in terms of metabolic and endocrine problems, of course, they develop hyperglycemia. If they already have diabetes, their diabetes will get worse. So if you have someone with an A1C of 10%, you want to start them on steroids, it's going to get much worse. So ideally, you will look for an alternative to steroids, or maybe if you have time, you want to first control their diabetes and then start them on the steroids. Otherwise, they might end up in the hospital with severe hyperglycemia. And I've seen patients come into hospital with, for example, a hyperosmolar state and HHS, which is a hyperglycemic emergency because they had, at baseline, they had bad diabetes, and then steroids were added on top and precipitated things and made them much worse. Patients with type 1 diabetes can develop DKA if you put them on steroids, especially if it's not well controlled. So you really want to, if they have diabetes and they're following with an endocrinologist, you want to kind of liaise with your endocrinologist, coordinate with them the fact that you're going to start steroids, so we can have a plan for what to do when the blood sugar goes up, because it will definitely go up. Patients who don't already have diabetes might develop diabetes when you give them steroids. So we call this steroid-induced hyperglycemia or steroid-induced diabetes, which again, you need to tell your patient about so that they are ready, and when it happens, they will not be upset at you for giving them diabetes with this medication. The other thing we will talk about a bit more towards the end as well, which is HPA axis suppression. So as you know, the adrenal gland is where steroids are made. Let me try to use the pointer there. So you got the adrenal gland where steroids are made. This is adrenal gland here at the bottom. And it is stimulated by the anterior pituitary, which produces the ACTH hormone that stimulates the adrenal gland, which in turn is stimulated by the hypothalamus. And then when there is cortisol in your blood or in the patient's blood, this cortisol will cause negative inhibition at the level of the hypothalamus and the pituitary to prevent the release of CRF, which is a corticotroph releasing factor, as well as ACTH, which is adenocorticotroph hormone. So ACTH and CRF or CRH will both be suppressed when you have a lot of cortisol. Now this happens normally if you have physiological levels of cortisol. This gives you a balance or homeostasis where cortisol levels are kept at physiologic levels. But if you give someone a lot of steroids exogenously, such as when you give them a high dose of prednisolone or cortisone, then you will suppress the hypothalamus and the anterior pituitary to a degree where this whole axis might become suppressed and will not recover. So when you stop the steroids, the axis doesn't start working, doesn't make any cortisol. So usually they tell patients, the kind of layperson way of explaining it is the glands become تصير كسلانة الغدة تصير كسلانة لأن عطيناك وايد جرعة من برا. So your gland becomes kind of like hypoactive because it's got used to getting a lot of steroids from outside. So it's a nice way to explain it to patients when we try to treat them for it, and especially during withdrawal. All right, so what are we going to do during therapy with steroids? We're going to try to treat all of those complications. So, diabetes, again, contact your endocrinologist, poorly controlled hypertension, heart failure, all of those things. So ideally, if someone already has heart failure, you want to avoid giving them steroids, but if you really must and you have no choice, then you want to organize it very well with the cardiologist and similarly with glaucoma, peptic ulcer disease, all of those things you want to treat. I just want to focus on infections a little bit, so you want to monitor for infections for sure, but also some patients who are not vaccinated, you want to make sure they get all their vaccines. So if they haven't received the pneumococcal vaccine in a while, if they're not getting their any other vaccines that they might get, COVID vaccine included, maybe you want to make sure that they are vaccinated and up to date with their vaccines before you start them on therapy. But you have to be careful with live vaccines because live attenuated vaccines might suddenly become hyperactive in a person who is immunocompromised with a lot of steroids. So you can give it to them before you start the steroids, or you can stop the steroids, wait for a month, and then give them a live attenuated vaccine, but you shouldn't give it to them while they are receiving steroid therapy because they would be immunosuppressed. Finally, for osteoporosis, anyone, please, anyone, you start on steroids. In the same prescription, when you write prednisone 40 milligrams once daily, you also write calcium and vitamin D. That has to be standard. Give it to everyone. There is no harm in giving anyone calcium and vitamin D, and there is absolutely benefit, with demonstrable benefit. And if you're worried, you can send them to an endocrinologist as well to consider treatment for osteoporosis with anti-resorptive therapies, but at a minimum standard, you have to give everyone calcium and vitamin D. This is standard of care, and you shouldn't ever prescribe steroids without calcium or vitamin D. Okay, so one thing I want to also remind you of, and I've noticed that some people have forgotten this, and we used to know it all in medical school. I'm an endocrinologist, so I'm used to it, but I think some people have forgotten about this. And I've seen patients who were on, for example, hydrocortisone 20, and then during COVID, they were not able to reach their primary or the doctor who was helping them, so they would go to see someone else, and then the hydrocortisone was not available for a while. So a lot of patients were switched from hydrocortisone 20 milligrams to prednisone 20 milligrams, and this was a big mistake because this is 4 times the dose, much higher dose. So you need to be careful about the type of steroid you're using. So I've shown here 3 examples just because I wouldn't want to put a really big table here with small font. So we're focusing on those 3 examples, but similar to hydrocortisone would be cortisone, would be somewhat similar to hydrocortisone. Prednisone, similar to prednisone, methylprednisone or prednisolone, slightly different in terms of their equivalence, but kind of in the same ballpark. And then you've got dexamethasone with betamethasone in their own category as well. And those are the longer acting cortisones. Generally, when you want to treat patients, you want to use prednisone as opposed to hydrocortisone. So we use prednisone and dexamethasone for patients with skin conditions, with joint conditions, because because prednisone, compared to hydrocortisone, prednisone and dexamethasone are better at penetrating the underlying soft tissues. Hydrocortisone is more likely to stay in the blood vessels, which is good for cardiovascular effects. So that we give hydrocortisone to patients who have adrenal insufficiency, or when they come in adrenal crisis, their blood pressure is very low, we're trying to raise their blood pressure, that's when we use hydrocortisone. But if you're trying to treat the skin, you're trying to treat the soft tissues, you're trying to treat the joints, you want to give prednisone, which doesn't bind to protein in the blood, goes through the soft tissues and the and outside extravasation of the steroid. Now, the final part is probably what I can help you the most, is stopping systemic steroids. So what I'm going to try to do here is to focus on a few principles of tapering steroid therapy, because we get a lot of questions about this all the time. When you're trying to withdraw steroids, right? If you have a patient on, let's say, 40 milligrams of prednisone, they've been taking it for 3 weeks, 4 weeks, their condition got better now, and you want to now start thinking about stopping it, okay? There are 2 reasons why you want to withdraw it slowly. The first reason is disease-related. So, they have the skin condition, right? And you're giving them the steroids for their skin condition. So this is disease-related. If you drop it too quickly from 40 milligrams to, just completely stop it, they might have a relapse of their condition. So this is what I mean by disease-related. This is related to the condition to which they need the steroids, okay? So you want to go slowly here. As an endocrinologist, this is really up to you. I don't care how fast you go down on the dose, from 40 milligrams down to 5 milligrams of prednisone. This part of the tapering, I don't care how fast you do it. It's up to you. So it depends on the condition. You're the experts in this area. Can we drop it very quickly, or do we have to go slowly? Depends on the condition. So are they have high risk of relapse after stopping steroids? So I'm not a dermatologist, but I believe this is the case for certain conditions. such as psoriasis, for example, they might get a relapse, right? So you might want to go slowly, or maybe you don't want to use steroids, you want to use something else, which is even better. But just as an example. So here it's up to you. Once you get down to a dose of prednisone 5 milligrams, then the benefit you're getting for disease is a lot less. You're basically now giving them physiological replacement of steroid therapy. This is when you have to worry about adrenal insufficiency, okay? So this is where you have to go really, really slowly, because what we're trying to do here is, because we said the adrenal gland and the HPA axis has been suppressed, and we want the HPA axis to wake up. And if we go very slowly, we allow it to slowly to wake up and start making cortisol endogenously, normally. But if we stop the therapy immediately, their axis is suppressed, they will develop adrenal crisis, and they can come to hospital with low blood pressure and repeated vomiting or severe fatigue, dizziness, reduced weight, reduced appetite. Those are all symptoms of adrenal insufficiency they can get from stopping too quickly. So I talked about the HPA axis. I'm not going to go over it again. I already explained it. Okay, so another important point here. So how do you know if the patient has now had a suppressed HPA axis or not? Because this will determine whether or not you can stop the steroids right away. So we classify them into 3 groups, okay? So this is from up to date, but it's also consistent with a lot of literature, although we don't have a lot of evidence for that. But this is similar to what we do in practice as well. This is what a lot of clinicians practice the same way in endocrinology. If you've only given them steroids for less than 3 weeks, so up to 2 weeks we can say, you can stop it right away. So if you give them a course of 5 days of steroids, don't worry about tapering. Give them 5 days, you can stop it, that's fine. As long as it's fine from a disease point of view, as endocrinologists, from HPA axis suppression, we're not worried about suppression. You can just stop the therapy. Or if you're only giving them prednisone 5 milligrams in the morning, okay? And in the morning is important, okay? So if it's only 5 milligrams or less than 5 milligrams, so you're giving them 2.5, so half a tablet per day, or every other day, 5 milligrams every other day, even up to 10 milligrams every other day, that's also fine. We consider them to be non-suppressed. So in those 2 cases, you can just stop the therapy, okay? The steroids. On the other hand, if they're getting more than 20 milligrams of prednisone for more than 3 weeks, okay? So it's neither less than 3 weeks, nor is it less than 5, so it's more than 20, and it is more than 3 weeks, then we say, this patient, we assume that they have suppression. So we cannot stop right away. There is absolutely no excuse for stopping therapy right away in someone who's been getting this high a dose for this long. So you have to assume that they have suppressed HPA axis, and we have to be very careful about tapering it. The other thing that sometimes they talk about is cushingoid features. So if the patient develops cushingoid features, then we say by default, if they have cushingoid features, we assume that they have HPA axis suppression, because it means they received a lot of steroids already, and it's showing in their body. So the same way it's showing in their skin, it must be also showing inside in terms of their HPA axis suppression. And then we have this intermediate place where we say we're uncertain if it's suppressed or non-suppressed. Usually with those patients, you can still stop, but you have to be very careful and monitor them, okay? So you can treat them similarly to non-suppressed, but you have to be very careful, right? So it's different than here, where you just give them as an outpatient, tell them, take this for 5 days, then stop it, no problem. But this patient has been on it for a longer period of time, for 5 to 20 milligrams, more than 3 weeks, let's say 10 milligrams every day for 2 months. You cannot just stop it. You will stop it, and then you will monitor them. You bring them up, maybe bring them back to clinic, see them a week later, make sure they're not developing symptoms of suppression. Similarly, any patients who receive prednisone at night. This is important because at night is when we get the big rise with the circadian rhythm, big rise in ACTH and other hormones as well that happen overnight. So if you give them prednisone at night, you suppress that. So that's much worse. Giving prednisone at night is much worse than giving prednisone in the morning. So we always give it in the morning. So this is just what I just said, which is what do we do? So how do we stop steroids based on the risk of HPA axis suppression? So we said if it's non-suppressed, we don't need to taper, we just stop it. If it's here where we're not sure, then we say no need to taper for most patients, but we have to be careful, especially if, for example, they're planning to go for surgery. If they go for surgery, they're going to undergo some stress. In that case, you might want to give them stress doses of steroids because we're not sure. But here, when it's suppressed, for sure you have to taper carefully. So what do we mean by taper carefully? So I've showed you this table, kind of like a generic table. You will have to modify it according to the disease, especially for the part from above 10 milligrams. So those 3 rows at the top, this is up to you. You can change it as much as you like, because remember in the graph I showed you before, this is the part that is disease related, okay? So if the disease, from your point of view as a dermatologist, okay, you think that it's okay to taper quickly for this condition, that's fine, okay? But once you get here, okay, to 10 milligrams, this is when you have to be cautious with suppression of HB axis. And the speed with which you taper depends on the dose. So when you're starting with 40 milligrams, you can taper quickly. You can go from 40 to 30, no problem. Then 30 to 20, no problem. But once you get to 20, okay, or sorry, once you get to 40, so you go from, you can go from 80 to 70 to 60 very quickly. You can drop by 10 milligrams every 1 to 2 weeks. Once you get to 40, so between 20 and 40, you reduce that. You go a little slower. Now you're getting smaller. So you're going to go a little slower. So you can think of it as we are tapering as a percentage of the dose. So as the dose gets smaller, we taper by smaller increments or decrements. So we go from 40 to 35, from 35 to 30, from 30 to 25, and then to 20. Once we get to 20, we go even slower. So we go from 20 to 17.5, so that's 3 tablets and a half. Then from 17.5 to 15, and then from 15 to 12 and a half, and then to 10. Once you get to 10, then you have to go even slower than that. So what I like to do, because we don't have a lot of the doses that are available outside, so they have 1 milligram doses and that sort of thing. But in Kuwait, I believe we only have the 5 milligram dose, maybe a 40 milligram as well, but 5 is what we usually use. So when you have a 5 milligram tablet, what you can do is you can alternate between days. So you say, on the first day, you take 7.5 and then 5. So you alternate between 7.5 and 5. Then you alternate between 5 and 2.5. Then between 2.5 and nothing, so every other day you take it, and then you can stop. So this would be, each one of those would be for 1 week, maybe even up to 2 weeks. So you're gonna spend a lot more time here actually than here. So this might take you, a month, and then another month or 2 months even, just to go from 10 milligrams to nothing. Okay, so this is the insight I wanted to deliver here regarding from an endocrine point of view. I will stop here. Thank you very much.